Hello, and welcome to the ICA's Conversations with Expert Speakers series. We are delighted that you're here with us today to learn about interstitial cystitis or painful bladder syndrome in the context of chronic regional pelvic and genital pain from Dr. Robert Echenberg. Please note that this session will be recorded. So if you're on camera today, your video is going to be included in the recording. We will have a Q&A session following the presentation. If you think of any questions about today's topic during Dr. Echenberg's presentation, please feel free to go ahead and post them in the chat. Once the Q&A session has started, you may also use the raise hand feature in Zoom. You would then need to unmute yourself, at which point you can ask your question verbally. If you aren't speaking, please be sure to stay muted. Dr. Echenberg will answer as many questions as he can during the webinar. And finally, please complete the post-webinar survey. You will be able to find a survey link in the chat. It is time to get started. Dr. Robert Echenberg began private practice in Bethlehem, Pennsylvania in the early 1970s as an OBGYN. Aside from his comprehensive OBGYN routine medical and surgical care of women, the first 35 years of his career, in large part, was devoted to advocating for women and their families. His interest in chronic pain began in 2001 while developing a hospital-based program designed to create a non-surgical approach to the treatment of chronic pelvic pain. He soon joined the International Association for the Study of Pain, started reading scientific journals on pain, and attended numerous pain-related conferences and seminars. Dr. Echenberg's passion for patient advocacy and integrative care in women's health continued with his creation in 2006 of the first privately owned pain management practice specializing in the assessment, diagnosis, and treatment of chronic pelvic pain, genital, and sexual pain disorders. Through his website, www.theechenberginstitute.com, both women and men continue to reach out to him worldwide. So without further ado, please welcome Dr. Echenberg. And Dr. Echenberg, you are still muted.
Okay, now, all right. Can you hear me now?
Yes.
Yes, okay. Sorry about that, everybody. We got everything straightened out. And I thank the organization for having me. And I congratulate the ICA on its upcoming 40th anniversary. And I'm pleased to meet with all of you. So what I'd like to, Lee's introduction actually took several of my early slides. So I'm going to go through everything fairly quickly. And I wanted to add right off the bat that I'm talking to you from Pennsylvania, where my practice has been for a number of years, as you heard. And a lot of the slides that I am going to show you, I actually show to new patients on a consultation with a new patient. And those consultations usually take about 2 to 2.5 hours. So we're going to show you more slides in less time. So I'm going to be kind of going through more slides than you might be able to absorb real easily, but because I want to show you an overview of what we developed and how it fits in, how painful bladder syndrome IC fits into all of that. So with no further ado, I'm going to move ahead and show you as Lee said, my transition in 2001 after 35 years of practicing OBGYN. That's actually me on the left delivering a young baby, a newborn from a C-section. And that little baby is now probably 40 years old and may be a parent or even a grandparent by now. So you see, as OBGYN, like a lot of the pelvic specialties, is surgically oriented. So to become a non-surgical pain management practitioner of the pelvic region, first of all, we have to talk about what is the pelvic region. When we talk about pelvic pain in general, It's not just about one part of the pelvis, not just the genital area, not just endometriosis, and all of the parts that you may have kind of put into your mind about IC and endometriosis and the common things that cause pelvic pain gynecologically or urologically, but the entire pelvis from the midline belly button area to the mid thigh. So you can see that there could be painful issues in the pubic area, in the tailbone area, actually in the low lumbar area, in the hips, on the genital area, in the buttock, all the way around. And so we're dealing with um, pain that can occur anywhere from here all the way down to here, especially in this region right in here. So the definition of it's important to understand that we're dealing with more than just the usual things that you think about. So there were and still are no certified fellowships or residencies in non-surgical chronic pelvic pain management. Many educational interdisciplinary barriers to do that. I've been working very hard for a number of years through the International Pelvic Pain Society and other directions to try to get that improved and get some education into the OBGYN and urology and urogynecology programs, but it's very difficult to break through. So many of you are probably familiar with Dr. Nickel from Canada. In the last couple of years, there's been more interest in how he put these 9 phenotypes for IC and painful bladder syndrome. All the different types of presentations that people with IC may have. So the pelvic floor and urethral and sexual hypersensitivity with widespread pain, all of these different ways in which IC patients get confused as to what's going on totally with them and why are there so many presentations with people with IC. I'm going to change that around a little bit because after the first year or two of seeing patients on my own with pelvic pain in general, typical complex of pelvic painful problems are often associated with various combinations of these symptoms. And I would show this picture to all of our new patients when I first saw them. And they would look at the bladder symptoms and irritable bowel symptoms, the lower abdominal bloating and pressure, vaginal itching, burning, and sensitivity, along with the vulvar pain, burning and itching, sexual pains of all type, entrance during and or after intercourse, and lower back and or lower abdominal pain. So people would look at that and say, how did you know that I was coming to see you? Because some of the people would have 2, 3, or 4 of these things and were wondering, had already gone to the GI doctors and to the urologist and the urogynecologist and the regular GYN and all sorts of specialists, and as many of you probably have done. So I'm going to move on here and show you how I like to link things together like this. And I didn't put this together. This came from a group called the Overlapping Pain Syndrome, put together by a number of people about 10 or 15 years ago, including the NIH. So you can see very quickly that the things we're talking about with pelvic pain, the IC, vulvar pain, irritable bowel syndrome, even endometriosis and fibromyalgia being widespread pain. And then you go down here with TMJ, chronic low back pain, chronic migraine, and chronic tension type headaches. And then ultimately chronic fatigue syndrome, which probably many of you who are on the call right now feel like you are chronically tired and chronically fatigued. So what puts all these things together? What is the thread that hooks them all together? And that is they all are pain syndromes and pain illnesses or disorders, whatever way you want to put it. And you can see immediately that some of you may have TMJ and chronic low back pain and migraine along with your IC. So many people look at this picture and tell me, Yes, I have 3 or 4 of those things when I show it to a new patient when I'm talking to them online. So I decided that I didn't want to end up being the doc sitting here with the woman saying, I hope you're not going to be like the 20 incompetent doctors who couldn't find anything wrong with me. So in order to do that, I had to do what Lee's introduction was a few minutes ago. I started reading 2 textbooks that probably most of you don't even know ever existed. They came out both around 2000, around the time that I was getting interested in all of this. And so this book on the left came from Dr. Steege is the main author of that at the University of North Carolina, Chapel Hill. And the pelvic pain book over here, Fred Howard was the founder of the International Pelvic Pain Society. And there's many, many contributors to this textbook as well, including this Dr. Paul Perry, which you can barely see there, but I'm going to point out to you about him a little later on because he was a big influence on me. So I started reading, as Lee said, and I joined the International Association for the Study of Pain, which is a worldwide organization. The American Pain Society is a part of the International Association of Study of Pain, which represents pain organizations from around the world. I think there's about 80 countries that have their own pain um, um, uh, associations. And reading the journal Pain, which is put out by the IASP, reading the Journal of Pain from the American Pain Society, and then also joining the International Pelvic Pain Society, like I said, in the early 1990s. It had been established only, well, I joined in 2003. Um, it started in the mid 1990s by those people who were pretty much ahead of their time, most of which were involved with those 2 textbooks that I told you about. So the International Pelvic Pain Society I went to first in 2004. And among many other people that I heard talk there over the years, right near the beginning, I heard Dr. Daniel Clow, who's from the University of Michigan, board certified completely in anesthesiology, rheumatology, and psychiatry. That's very unusual for somebody to be boarded in that amount of different parts of looking at medical care. He is the director then and still is the director of the Chronic Pain and Fatigue Research Center at the University of Michigan in Ann Arbor. He gave a talk called Neurobiology of Chronic Pain, Lessons Learned from Fibromyalgia and Related Conditions. So part of his talk, and um, I'm going to just show you that other people also put these same things together. The combinations of migraines, TMJ, and constitutional symptoms such as chronic fatigue that we just talked about, sleep disturbances, idiopathic meaning unknown reason for low back pain, irritable bowel syndrome, paresthesias like tingling or crawling sensations anywhere in the body, memory and cognitive difficulties, multiple chemical sensitivities and allergic symptoms. I'm going to skip over some of those, but go down to the very end here. You see interstitial cystitis, painful bladder syndrome, femoral urethral syndrome, and vulvar vestibulitis and vulvodynia. So all those things were included way back in 2000, um, connecting them all to basically chronic pain as compared to acute pain. I don't have the time today to go into the differences between acute pain and chronic pain, other than to say that acute pain we need to have for protection because we need to know if we damage some part of our body. Chronic pain, on the other hand, is a totally different pathophysiology of the nervous system, and then it becomes very complex. But I like to keep things with our patients and with giving these talks as at as simplest level as possible, so we all can understand. So Dr. Clow, who I just talked about, in that very first talk that I heard him give, put up a slide like this of the spinal cord and the brain, and whether signals were coming from structures or from organs. So organs and structures, meaning visceral and somatic triggers. And the signals would go into the spinal cord from wherever you're talking about in the body. And let's pretend that this is the pelvic area. And that could be the bladder, that could be the bowel, or that could be the GYN structures. All of the other structures, including the skin and the nerves and the muscles and the ligaments and the joints, all of those parts of the pelvic area are part of the somatic part, the structural part of the pelvis. So any signals signals that are coming up from the pelvic area ascend as generators of signals that reach the brain and say, oh, I can't sit comfortably. Oh, I have pain with entrance with intercourse. Oh, I have pain with my bladder or my bowel. And immediately, wherever sensitivity is coming from in the body, including whether it's coming from the lower back or the shoulders or the knees, there's immediately inhibitors that are supposed to be released. And these are the biochemicals and neurochemistry that most of you have probably heard about. The inhibitors being serotonin, norepinephrine, dopamine, and all the other neurochemicals, including adrenaline, which come back and turn the kind of balance off the generators. So in a healthy, normal person, the inhibitors are countering and are equalizing with the generators, because we all have aches and pains and we keep it under the radar. But when chronic pain occurs, there's a total different change physiologically in the whole nervous system called central and peripheral sensitization. And the term neuroplasticity comes up. And what we're talking about is when the generators are constantly outweighing the inhibitors, that is the picture of chronic pain versus acute pain. And the clinical people that they were working with to show this kind of simplistic look at chronic pain was fibromyalgia patients. So in the case of fibromyalgia, the generators are outweighing the inhibitors constantly throughout the body, and people can get, one day they may have pain in their back, one day they may have pain in other parts of their body, and so forth. The inhibitors, however, are overwhelmed by the generators, but the inhibitors keep trying to come down to balance out these generators, but they just can't do it. And that also leads to the body becoming extremely fatigued, physiologically fatigued, because the inhibitors are trying to be released. Our goal in our treatment of patients with this kind of model is to help people slowly understand how they can learn and how to reboot their brains and their nervous system to release these inhibitors, because those inhibitors are stronger than opioids and gabapentin and Cymbalta and many of the drugs that you may have tried in the past for your pain issues. So we would like those inhibitors to come from our own system to help turn down the pain issues. I'm sorry, I'm just going to take a sip of water. Okay. And move on to, so what he showed is, in this slide, was this dial, like a volume dial, that is wound up when the generators are outweighing the inhibitors. So our goal is to, this metaphor of the volume dial I've used for many years. So most of my patients, when I just turn my hand a little bit like so, they know what I'm talking about. This past week or this past month, where has your dial been? And it also explains why almost everybody with chronic pain cannot figure out why Tuesday was a good day and Friday is a horrible day. Everybody's looking to figure out what the triggers are. And that's where it gets more and more complicated, but let's keep it simple. So the explosion of neuroscience was happening right around the time that I got interested in all of this. So the term central and peripheral sensitization, the term wind up, which is like winding up the volume dial, neuroplasticity, which is a term that most people are starting to hear about in the chronic pain world, is a good word because it means that the dial can actually be turned down. Up until about 20, 30 years ago, they felt that if there were injuries or neuralgias or neuropathies and so forth to various nerves and structures in the body, that was not repairable. We now know that it is repairable because of the plasticity of the nervous system. Neurogenic inflammation, I'd like you to just absorb that term for a moment and realize that when nerves are firing off into any area of the body and overly firing off, like in a neuralgia or neuropathy, there's inflammation at the end point of where those nerves are firing off. And if those nerves are firing off in very sensitive areas of the body, like the face or the fingertips or the toes or the genital area, those are the most sensitive areas. So we're going to talk about how when those nerves are firing off into the genital and deep pelvic area. So the busiest part of the body, everybody has seen this picture a gazillion times. It was drawn by somebody 100 years ago about the pelvic area. It's on all of your gynecology doctors' walls when you walk into the examining room. And even in middle school, this is the picture that everybody knew uh, uh, on, in health class. And basically it's wrong in about 100 ways. One is that all of the structures in here just are meant to show that the bladder and the uterus and the GYN structures and the lower bowel are the main organ systems in the deep pelvis. However, on that picture, you do not see any nerves, muscles, ligaments, or anything else. Look at all the nerves that actually are coming down into the pelvic area because there's so much going on and all the muscular stuff. And I'm going to show you more muscles in a little bit. But look at this muscle right here, that psoas muscle on either side. That muscle you can see, and I'll show it to you in another picture. I'm sorry, my little device here is jumping all over the place with me at the moment. I'm sorry. So I'm going to show you in a little bit how that muscle, if that goes into a Charlie horse, that can take people to the emergency room doubled over in pain. And that some of you may have had that happen over the years. I don't know, but we'll talk more about that in a moment. But the pelvis in general, and again, the pelvic region being between the belly button and the mid thigh, is prone to physical, sexual, functional, surgical, athletic, and accidental traumas. And Dr. Fred Howard, who was the main author of the textbook that we showed you, just a few years ago, wrote in an article, "Don't overlook this disease when a patient complains of pelvic pain. As many as 85% of women who seek care for chronic pelvic pain in general have IC and painful bladder syndrome. Studies show instead of or in addition to a gynecologic diagnosis, I'm going to add to that, or a hip diagnosis, or a pubic pain diagnosis, or a tailbone pain diagnosis. So we get into people who are actually seeing orthopedic doctors and low back pain doctors and all of the other areas of the pelvis that I just showed you. So here on page 3 of our 17-page questionnaire that we send to all of our patients before I do that 2.5-hour call with them, you can see when we ask where is the areas that hurt the most in your body. And some people draw all over the body, like a fibromyalgia patient would be. But this is one particular 65-year-old woman who drew this whole area around the vulvar region and around the genital region here, and several spots here where she had sitting pain. And in her case, she was one of our patients who had persistent genital arousal disorder, a hyperarousal sensation that almost 90% of which have IC. And I'll try to explain that a little bit later, but I'm not going to talk about the arousal disorder. There's no time today. But that was her primary complaint. and she saw a nationally renowned urogynecologist who never mentioned vulvodynia because he never had her draw anything like this, and all she was talking about was her arousal and sitting pain. So a neurosurgeon gave her some spinal blocks, and she probably saw about 13 other specialists. And finally, when we saw her and she drew this thing, just by drawing that, when we say draw where your pain is, vulvodynia, dynia means pain in the vulvar area. So it's a descriptive diagnosis by saying any type of persistent pain in this region of the body, in the external genital region of the female and even of the male, is in the woman is called persistent vulvar pain. And so you can see the overlap there. So we ended up finding that actually she had a lot of peripheral neuropathies and trigger points in the musculature of her buttock area and around the vulvar area and around the lower abdomen area. And I'll talk to you about the treatments that we do a little later on here. But looking at a 34-year-old woman who filled the same thing out, you can see all the sensitivity around her waistband and the lower abdomen and hip area and the vulvar area. She was treated for stage 4 endo over and over. Uh, she went to a nationally prominent MIGS means minimally invasive gynecologic surgeon. She had at least two laparoscopies after I saw her in 2013 or 14. She had never been given a diagnosis of IC, even though she had a puff scale score of 23. Some of you may know what I'm talking about when I say puff scale score. I'll show it to you in a minute. She also had irritable bowel and severe vulvodynia and sexual pain. None of them were diagnosed, unfortunately, by the gynecologist, who was only interested in the stage 4 endo. So the endo was definitely one of her triggers, but not the only reason for her pelvic pain. Also, she was one of the women and people that I see who herself said, having pain is just part of being a woman. I don't believe in pain medication. I just suck it up. So that adds to the issue as well. And people have a very high pain tolerance because they've had so much pain for so long. So what we do, non-surgical medical management, we're taking care, again, of generalized vulvar pain disorders, localized vulvar pain disorders like the vestibule and the labial area and the clitoral area, the perineal, perianal, and groin pain. I'll explain if some of you don't know what the vestibule is. We'll be talking about that in a moment. All aspects of sexual pain. Male pain, we see men as well, penile, scrotal, perineal, groin pain. And some of those gentlemen and some of those young guys have erectile and ejaculatory pain as well. Bladder pain syndromes, as we're talking about today, irritable bowel pain, and persistent general hyperarousal spectrum of disorders. I don't have time today again to talk about those directly, but also buttock, hip, tailbone, and sitting pain, and unexplained lower abdominal pain. So I can sense that probably all of you at this point are saying, yeah, I may have some of those things as well, other than my just IC. Here's the puff scale score. You can't see it really very well there. And a lot of you have probably filled out that puff scale, getting to someone at some point to get a validation of at least the beginning validation of diagnosing your IC. So since in the early 1990s, this puff scale was put together, centering on frequency, urgency, and pain, increase with holding your bladder for too long, and with sexual activity. So some of the questions are involved with sexual pain issues, and most of them are dealing with frequency and urgency. So if we break IC down, frequency, urgency, and pain associated with the bladder is kind of the most simple way to look at IC in general. And I started out in 2020, in 2001, 2002, and 2003, mostly screening people for PBS and IC with the puff scale and then examining them very carefully with a single digit exam. And the clincher was, yes, they had a high score. Yes, they had frequency and urgency. And just putting a finger in the vagina and just gently pushing upwards onto the base of the bladder. And if that's tender and they say, oh my gosh, that's exactly where I've been trying to tell my gynecologist where I have my pain, that almost clinches, unless somebody actually has an active UTI at that moment. But as most of you know, UTIs and flares of IC are constantly mixed up with each other. So if we already have ruled out the infection part, and today we're going to talk a lot about uh, inflammation without infection. And if you think about IC, it's a big inflammatory issue of the lining of the bladder, lining of the urethra, and as I'm going to tell you in a moment, the vestibule of the vaginal opening as well. So in our program, we have now seen over 2,200 complex pelvic, genital, and sexual pain patients over the past 23 years from approximately 39 states and 20 other countries. Close to 70% of these women and men have been found to have bladder-associated symptoms when the right questions were asked. And what do I mean by that? Because a lot of people come in with all kinds of other symptoms that I see that I've already kind of explained in other parts of their pelvis, and they don't even complain about their bladder because they don't even consider their bladder as being ground zero. The bladder and urethra may or may not have been their ground zero. So they come in saying, I can't sit, I have sexual pain, I've had 3 surgeries for back pain, um, and they don't even mention that their bladder's a problem until you say, are you one of the people that has to pee before you go to the movies, during the movies, after the movies, when you walk in the mall, you need to know where all the bathrooms are? And people say, oh my gosh, yes, I have been that. But I never thought that that was any part of my problem. So we have people that don't even realize they have bladder issues and they're coming to see us, and vice versa. Often people will come specifically because they have not been able to find anybody to treat the pain associated with their bladder. But we find out that much of their pain that has been blamed on their bladder is actually a lot of the other things that I'm talking about today. So there's a big spectrum, because there's a lot of people, as you most of you know, who have IC under the radar and just look at it as a nuisance issue if it doesn't cause severe enough pain. So again, if you can see that, back to the pelvic region, any kind of pain in any part of that region can be associated with urinary frequency and urgency, like I told you before. So I'm going to move on here a little bit. The predisposing factors for chronic pelvic, genital, and sexual pain. This is very important. The 20% of the population of the world has a genetic predisposition for chronic pain disorders. That doesn't mean that that 1 in 5 people in the entire world will end up with the worst case scenario of pain, but chronic pain actually challenges our healthcare system and takes more resources totally than diabetes, heart disease, stroke, and cancer put together. So around the world, chronic pain and chronic low back pain, which is the most common representation of chronic pain, is the most common diagnosis in the world. And when it's placed into the pelvis, it becomes also one of the most common things. So the next thing, besides being genetically predisposed, is a history of cumulative bodily traumas. Injuries such as previous pelvic surgeries, childbirth, accidental traumas, falls on the coccyx bone, straddle injuries, often long-term pelvic stress from sports and other physical activities. So believe it or not, we see people who have had no accidental trauma, but have traumatized themselves by, and I'll show you in a minute what I'm talking about, through over exercising. cumulative emotional, psychological, abusive, surgical, workplace, relationships, financial loss and grief, and all other lifetime stresses and traumas, both large and small, large and small. So we all have traumatic experiences throughout our lives. And when I talk to new patients, we talk about how each time we go through a trauma of any sort, whether it's minor or major, there's something that occurs, and I'm going to show you that in a moment. Functional pain disorders in the pelvis would be IBS, would be IC, would be severe dysmenorrhea, even without any evidence of endometriosis. And finally, even good traumas. And what do I mean by good traumas? Here's a picture showing all the good traumas. And we're going through the Olympics right now, and we know that men and women in all these pictures and dancers just concentrate on their pelvic region. The body's really not meant to do this. Um, think of the engagement of the pelvis in these runners and swimmers and gymnasts. And again, the body is not supposed to be able to do this. And some of you know Ehlers-Danlos syndrome. So you see people that can do this more easily than other people. And Ehlers-Danlos actually is one of the diagnoses that, because people are hyper stretchable, their joints are hyper stretchable, that puts more stress and stretch on the ligaments and the nerves and the musculature in the pelvic region. And when looking at all these perfect bodies, how do we know that any of these young women and young men might already, especially the young women, be starting to have sensitivity around the vulvar area? They can't put a tampon easily like their friends can. When they try to become sexually active the first time, they can't be touched. All of those things. How can we tell when we look at these people? But I'm telling you that 20% of these people statistically are already have some of those things in these perfect bodies. And 5, 10, 15, 20 years ahead, they may become some of the people that are sitting listening to this webinar today. And most of you have seen some of these books, like The Body Keeps a Score, Body Remembers, The Body Bears a Burden, where all of this puts together. These books talk about trauma and treatment, and you see how similar these names are. The Body Keeps the Score, The Body Remembers, The Body Bears a Burden. I used to tell people to read some of these books, but I'm going to tell you another book before we end today that I would like all of you to read if you haven't read it, and we'll get there in a minute. So cumulative traumas leads to further protective mechanism of fight or flight. And when we're in fight or flight and freeze and shutdown, which is when fight or flight is even more so, it makes the body and makes the whole nervous system feel highly stressed, fearful, and like a constant danger button is going off, because you just can't wake up each morning thinking, oh my gosh, what is this day going to be like today? Is it going to be a decent day? Is it going to be, am I able to take care of my kids? Am I able to go to work? Can I do what I need to do? Or am I going to be in bed all day? And that's one of the things that everybody that has any kind of chronic pain in their body, anywhere in their body, thinks about each day. So the dial can be up on one day. And again, I don't have the time to talk about much of the research that shows how stress and fear itself clenches up the body and makes things even worse. The actual causes of pain in chronic pelvic pain are mainly neuro and myofascial, meaning nerves and muscles. That's really important for you to know. The pictures I showed you earlier and right here, you can see that big psoas muscle right in there. And right over here is where the kidney is, and the ureter comes down. The ureter comes down, joins the bladder way down here. Then the urethra and all of that. So somebody comes in doubled over in pain, and they need and you're female. 70% of those young women have all the tests in the world. They have the CT scan and ultrasound. All their blood work and urine work shows almost nothing, or nothing at all. And they're discharged from the emergency room, 70% of them, with no diagnosis other than unexplained abdominal pelvic pain. And nobody has told them that maybe they've had a Charlie horse of one of these muscles. And many of the other muscles that are down here that I'm going to show you that surround all of these organs. And all of the nerves that are coming down here, because there's so much going on, both sensory-wise and motor-wise. So neuromyofascial, very important to remember that. So if you cut across like a MRI would, cut across the pubic bone and go straight back through the middle of the tailbone and look straight down, this is what all of us, including myself, if you remove the organs, would look like, male and female. Take out the organs and look at the musculature that's underneath and below in the pelvic basin, that this picture doesn't show any muscles at all. Look at the musculature in here. If you put the bladder in, it would be right under the pubic bone here. And then the uterus tubes and ovaries would be right there. And then the lower bowel would be coming down here. So anything exiting the pelvic area and anything entering the pelvic area has to come through this area open in the pelvic floor itself. So most of you have probably gone to pelvic floor physical therapists, but look at how huge this psoas muscle is. And you can see if the kidney is laying over that, and if the bladder's down here, and somebody's complaining of frequency, urgency, and doubled over in pain, it gets all mixed up, and people think you have a kidney infection because the pain goes through to the back. You can see how close to the psoas muscle is to the back. But then the physical therapist or a doctor who knows what they're doing can reach in this strange picture here, this weird picture, looking from above with the physical therapy digit coming in here and releasing the trigger points in the side walls. I'm not sure if any of you had ever really thought about thinking about muscles like that that are surrounding all of the organs here, including the bladder and urethra. So here's the urethra, here's the vagina, and here's the rectal opening, surrounded by muscle. And then on top of that, most doctors, even gynecologists, are not very trained or interested in the external genital area. So most of you who have had pap smears and have seen numerous GYNs or Urogyns and all the other people that are looking up inside to see what's wrong, how much time is ever spent actually observing or asking people, do you have any problem or itchiness in here? Or do you have any sensitivity in this area, which is the vestibule? And I can tell you that I have several patients who are female gynecologists who did not even know the term vestibule. And for those of you who do not know exactly what the vestibule is, it's part of the vulva, and it's the inside of the inner lips. And the opening of the vagina is a little deeper. The urethra comes out right below the clitoris, and that's the tissue that lines the vestibule, the vestibule skin on the inside of the inner lips. Everything I just showed you embryologically develops from the same tissue that develops the urethra lining and the bladder lining. So immediately you can see if there's a lot of inflammation going on in the bladder or urethra, almost always there's some inflammation going on here, and even vice versa for people that don't really have IC, but who feel sensitivity in their urethra and bladder area, maybe because of the vulvodynia that's going on. So you see that connection. So, and I'm going to tell you a little bit about vulvodynia. So the one thing here to remember also is that the vestibule itself is not part of the vagina. It's part of the vulva, and Vulvodynia and vestibulodynia are terms that are used, meaning dynia in the vestibule means pain in the vestibule, and the same thing for the vulva, meaning the entire region here. So the dial can be up there, and a lot of confusion between what you're being told are vaginal infections or UTIs or yeast infections constantly and all of that. Okay, so the study, there was a wonderful study in Australia with a woman who works with a group with a large group headed by Lorimer Moseley in the University of Adelaide in Australia. They studied, I don't remember exactly how many were in their study, but a very large, significant amount of women. And they asked them, what are the top most bothersome symptoms associated with your chronic pelvic pain? And they listed the top 20 in the research that came out. But the top 5 of those, first of all, levels of intimacy or sexual relationships, having painful sex with a partner, and even discomfort with self-pleasuring. Stomach and intestinal symptoms, meaning abdominal pain, discomfort, nausea, and bloating. Mood changes, anxiety, depression, anger, sadness, frustration. Inability to comfortably use vaginal tampons. And lastly, inability to sit comfortably for longer than 20 minutes. So there's no mention there in the top 5 of bladder symptoms. Bladder symptoms are in the list of the 20, but they're further down. So I want to point out that the most significant symptom revolves around sexual discomfort of one sort or another. I put together a few years ago a schematic, which I don't think anybody else has done in this fashion, to show the different arms of why women have sexual pain. Persistent vulvar and vestibular itching, burning, and pain that's unresponsive to treatments for vulvovaginal infection. So once again, inflammation without infection. So if there's no infection and the vulva hurts anywhere in the vulvar area persistently, that can cause sitting pain or entrance pain or any pain in the vulvar region, can be generalized or specified to the vestibule. The vestibulitis is the most common reason for entrance pain in any reproductive age woman from age puberty to menopause. Um, and the generalized vulvodynia can be broken down to nerve-related neuralgias and neuropathies, such as pudendal neuralgia and other nerves that I'm going to talk about to you in a moment. And then you have inflammatory dermatoses, such as lichen sclerosis and other inflammatory skin problems. The second arm is the muscles. The muscle spasming, why you go to a pelvic floor physical therapist, pelvic floor myalgia or hypertonic pelvic floor dysfunction. But there's also mixed up with the term vaginismus, which is basically the muscles of the pelvic floor clenching just because of the fear of anything coming near that area, usually associated with previous severe injury there or previous abuse. But all of those are acting on the muscle of the pelvic floor and the core musculature in general. The third arm, deeper pain triggers or the visceral triggers, like I explained before. Here's where the bladder comes in, lower bowel and gynecologic triggers. So you see, bladder is just one of many things that can be causing issues with female sexual pain. And then the last category down here is history of physical or emotional traumas. Years of sports, that's the good pain. The bad pain is over here with abuse, and then accidental traumas, straddle injuries, and multiple surgeries. Each surgery that you may have had, and I've had one woman who had 13 laparoscopies all for endometriosis from the time she was in her early 20s until her mid 40s when I saw her. She was still having the worst pain ever. Turned out she did have sexual pain as one of her major issues. She did have IC, she did have IBS, and she had very significant pelvic floor dysfunction. But the gynecologist who did all those in the same hospital by the same doctor finding the definition of insanity, doing the same thing over and over and not getting the same results, which were not good. So how are all these things linked? Because anybody that has the vulvar problems, the pelvic floor is going to clench in reaction. Anybody who has any of these issues with pain associated with bowels, bladder, or GYN structures also is going to have their pelvic floor clenching. And certainly anybody that has over uh, worked their core muscles and their pelvic floor muscles, like any of those athletes I showed you, they also are going to have tight muscles, but on purpose in many cases. But all of them put together, you can see how the pelvic floor physical therapists are the main people in our healthcare system who understand the connections here and who understands that chronic pain is eminent, preeminent in almost all of the people that they're seeing. So they do see people who have failed surgery and failed all of these other approaches, and they're the only ones that over the course of the last 10 or 20 years have multiplied around the country. And almost all of you probably have seen pelvic floor physical therapists, but they often plateau in their care because they're not all also taking care of the other things that may be going on, which can medically be addressed. So the Q-tip test, many of you have probably had that to see how much sensitivity there is at the vaginal opening in the vestibule. Here is uh, a young woman being checked. This was a picture that she allowed me to have taken of me checking right at the, and I'm going to show you this picture again in a moment, but it's basically right at the ischial tuberosity at the sit bone, which can be tender on both sides. And that tells me that somebody has either pudendal neuralgia or other nerves coming around from the back called the posterior femoral cutaneous nerves. And then you have that picture I showed you reaching in that the pelvic floor physical therapist would be doing. And finally, that other picture of me showing the gentle exam of the base of the bladder. All those things put together, along with examining their back and their hip area and turning them over. And again, I just want to remind you that the vestibule is derived from the same tissue as the urethra and the bladder. And you can see that this is obviously an extremely sensitive area to begin with. It's supposed to be a pleasurable area with all the nerves and muscles that are coming in here. But when those nerves are firing off too much, there's an inflammatory reaction, especially in here. So people can look bright red, can barely touch the vestibule. And of course, they get a discharge with that because there's inflammation going on and your body is reacting with a discharge, which it normally would do with an infection of any sort. So people are immediately looked at and said, oh, you have a yeast infection. We're going to do, for the 50th time, you're going to be treated for the yeast infection. So what I'm saying is that when these nerves are coming in here and causing inflammatory reaction, like I explained before, that's what we're talking about as far as the vestibular and vulvar pain issues that I deal with all the time. Here's me pushing again into that area, examining for the pudendal nerve, but also what's called the posterior femoral cutaneous nerve that comes around here from the back. And here's me examining a male patient to show you that we have men who come in and I put them in, aside from dealing and examining their back and their abdomen, we put them in a position like you're all used to. If they're with their wife or their girlfriend, they always are laughing because the partner is, because they see finally what a woman goes through all the time. So in the stirrups, we examine very carefully over here for that ischial tuberosity to check for pain, for pudendal neuralgia. Back in the buttock area here, the same as a woman and a man. And here I'm checking for the urethra, which is coming out after it goes through the prostate and comes up underneath the scrotal area and goes into the penis. And then men are telling me that they've seen 3 or 4 different urologists, all of whom have done just a rectal exam and told them that their bladder is inflamed and they're treated over and over for prostatitis. In fact, no one has ever checked them like I do, and most of those doctors should be doing, I think, and feeling the urethra as it's coming out onto the surface and just rolling over that area. And the male person saying to me, the patient saying to me, that's exactly where I've been trying to explain where my pain is when I'm sitting. Aside from the pain over here, they also have pain in here. So most of the male patients that I'm seeing have seen multiple urologists, and we finally diagnose appropriately that they have IC and urethral sensitivity. This slide's important because it shows that every sensation coming from your bladder, any sensation that's ever come from your bowel, and any sensation that's coming from your uterus all go into sacral 2, 3, and 4 in the tailbone and go up to your brain and say, I got to pee, I got to poop, or I have a period coming on, or a labor pain coming on. But it's important to note that off of S2, 3, and 4 is the derivation of the, I'm sorry, with the little mouse here, um, is the derivation of the pudendal nerve coming down here. So there's a connection, as you can see, between IC, IBS, painful GYN issues that can cross over and go down this way. And ultimately, if people have pudendal neuralgia or other neuralgias of the nerves coming in here, they also can transfer, not just go up to the brain and say, I'm burning down here, but can also come over here. And just to say that there's a connection between bladder function, bowel function, and dysfunction, along with the sensitivity down on the genital area. I don't mean to expose you, to sudden graphic pictures like this, but I wanted to do this because a 22-year-old who is demonstrating on the outside skin here already some scarring from lichen sclerosis at age 22. Because when we actually take a look and actually see what the cause of their itchiness is out here, and I tell them, if that's all you had, you probably wouldn't be seeing me because you would be just having some itching and irritation out here, not the cause of the severe pain when you sit or when you have intercourse, but inflammation nonetheless that can cause some scarring, even on a young 22-year-old, where the inner lip looks like it's disappearing. It's not really disappearing, it's just getting stuck to the outer lip. But at the same time, this patient also shows this inflammation in the vestibule. Here's the urethral opening, and way back in there is the vaginal opening. So the vestibule, again, is part of the vulva. And the reason that she has great discomfort with any touch in this area, including the Q-tip, let alone a dilator or a speculum, or certainly with intercourse, can't be touched anywhere in this area without it being extremely exquisitely sensitive. Look at all the nerves that are involved with pelvic pain, all the way up from T12, L1, L2, which is way up at the diaphragm, all the way down to the tip of the coccyx. And you see each color here and each color on these pictures here. Each color represents a different nerve root. So you can see how the brain has difficulty distinguishing between sensitivity that's coming from here or here or here. How would the brain know how to discriminate sensitivity that's coming from L1, L2, which is way up at the diaphragm, versus way down in the sacral area? So this is like a very tricky area. And back here, the same thing is a very tricky area. So I just want to show you this because it does show how when people have pelvic and genital and deep pelvic muscle spasming and sensitivity in any of these areas, it's very difficult to know why it's so confusing for the brain to say sometimes we put the Q-tip way back here and the person says, that's my clitoral pain, or that's my urethral pain. So it's brain is fooling the person and giving you the wrong information is what I'm trying to say. Because it is complicated, but we're just trying to show you that all of these areas in the pelvic region have their own separate innervations, but they all blend together. And ultimately, if those nerves are firing off, then the pelvic floor muscles are clenching around the rectum, around the vagina, around the urethra. From here back in the male and the female, you have the same musculature and around the vaginal area and even musculature around the urethra. When everything's clenched, it makes it harder to sit on the toilet and get anything out. And 5 minutes later, you have to pee again. Or your bowels, you're straining harder and harder because all these muscles are, it's not just constipation, but it can cause and contribute to constipation. And certainly anything going in or coming out of the um, uh, vaginal area becomes more difficult as well because of the clenching around all those openings. In the back and the right buttock area here, you see the sciatic nerve coming down. So many of our patients have been treated for, quote, sciatica, but there's also, and the sciatic nerve comes from way up at T12, L1, L2 as well. And the um, other nerve here called the posterior femoral cutaneous, you heard me say that, comes right down next to the sciatic and then sends little tributaries over in the deep buttock area here to the rectal area and around the corner to the perineum. So people that have sitting pain can be from the pudendal way back and underneath everything here, coming from the sacrum, but also these branches coming over here, which is a little further back in the buttock area, more towards the anal area. So when we examine people prone like this, we check all those areas and even give little injections into where some of the pathways are coming down here, just under the skin. Very tiny little amounts of lidocaine can be put into the tracks of the nerves coming down here, and then even doing a little bit of an injection a little deeper and safely into the butt area here, the buttocks, and kind of decreasing the sensitivity of the branches coming over here, causing the sitting pain. If you open up this area of the right buttock, surprisingly to most people that I show this to, here's the glute peeled back. Underneath the glute are all these layers of muscles going from the hip to the tailbone. The piriformis muscle that you've heard about hooks into the upper hip and goes to the middle of the tailbone. Somewhere in here is the obturator muscle that goes from the lower hip to the tip of the coccyx. And so you can see if any of these muscles are going into spasm or little mini Charlie horses, it can cause a person to feel like their tailbone is hurting or their hip is hurting when it's actually the muscle that's going into a little spasm. And it actually turns out, as I tell people, all these little muscles have a mind of their own. And depending on which exercise you're doing or how you're sitting or how you're moving around, some of them can go into little spasms and cause you to feel, oh, that's my low back pain, or that's my tailbone pain, or that's my hip pain. And people end up having hip surgeries. And I even have had some patients who have had their coccyx removed of all things and still have the worst pain ever because it wasn't their coccyx that was causing the pain. Um, so you have the PFC muscle or nerve coming down here and sending tributaries over here to the male scrotal area, which corresponds to the female vulvar skin. And in males, there's a there's a condition called burning scrotal syndrome, which is basically like vulvodynia. So all the mixture of the nerves coming from up high and from the sacrum, it gets very confusing and very, very complex when you really get into the anatomy of it. And I don't want you guys to think about that and overthink it. I just want you to show that it is more complicated in the deep buttock area than you might have thought. And there's the piriformis muscle. So when we have people, we can feel that piriformis muscle in the hip area, and I know where to put a little bit of local anesthetic as a trigger point injection to help release that. When it's released, here it is going from the upper hip to the middle of the tailbone, and here's the obturator. And when we put Botox into the pelvic floor, we actually put it a little bit into the obturator muscle and the pelvic floor muscles, and that can give people up to 6 months of relief of the pelvic floor. And I'm not talking about putting Botox into the bladder like some of you may have had, because I haven't seen anybody that has helped myself, but I'm not a urologist or urogynecologist, but I see the failures of that, and I see a lot of people who have had Botox into their bladders who are worse off afterwards. But Botox into the pelvic floor or part of the treatment stuff that we go through. So medical, here's how I look at treatments for all of these issues. I'm now at an hour and I just have a few more slides to go. So if it's okay with everybody, if I proceed, I'm just going to have a few more to talk about the treatments here. So a team approach, psychologist, acupuncture, yoga instructor, properly vetted websites, relaxation techniques, mindfulness techniques, all to lower the dial. But what can the doctor do? Doctor can do nerve blocks, doctor can do bladder installations, or a nurse practitioner can, and we can put Botox into the pelvic floor and recommend all those other things I just said. And that Dr. Perry, who I showed you in the front of the textbook, way back in the 1990s and before even, was doing showing how all these nerves were coming in from the front and the back, and how he was doing way back 25, 30 years ago, little injections into the abdominal wall, into the inguinal area. And I learned a lot from him, and I corresponded with him back in the late 1990s. And when I joined the IPPS, the International Pelvic Pain Society, we were supposed to meet at that first meeting that I went to. And unfortunately and horrible, he ended up with pancreatic cancer and died before we physically met each other. But I learned a lot from all that I had corresponded with him about, and that's how I started early on doing some of these in very minimal injections into very many areas of what I'm talking about. This looks horrible to put needles in here. This was a number of years ago. This picture was taken, but a lot of people have pain all the way across here and think it's their bladder. That's what we're talking about, putting just little bits of a 1 cc syringe that we do tiny little bits and show those people that, oh my gosh, all the sensitivity goes away right away. And and even into the pubic bone area here where people have a lot of tenderness, we can just put a tiny little bit up in this area across the bikini line. And lo and behold, within a minute or two, all of that sensitivity goes down. And we're not numbing the skin, by the way. We're just putting it subcutaneously in where the fascial layer has all of the sensory nerves. And then I learned Botox from a woman who wrote this book, Deborah Cody, and she and I worked together for a number of years in the International Pelvic Pain Society. And her book came out about the same time as the first book I wrote. I wrote it with Susan Bilheimer, who was a pain patient, pelvic pain patient. So together we wrote How Women's Sexual and Pelvic Pain Affects Their Relationships. That was about 15 years ago. And Deborah Cody's book came out. And she had been doing Botox into the pelvic floor in New York City for the previous 15 years. So if she had, unfortunately, she died of breast cancer a few years ago. So a lot of the people that I've been working with are not here anymore, unfortunately. And this is the new book that we're putting out, an ebook that I'm just finishing at this point, about kind of a memoir of how I learned all these things and all the stuff that we're doing. And ultimately, we're trying to turn the dial down. And here's that book that I want you all to read if you haven't read it already, by Alan Gordon, The Way Out by Alan Gordon. They are all psychologists who work specifically with people with chronic pain of any part of the body. But it's an easy book to read. It helps people with all of the top-down issues that they have with dialing up the pain and dialing up and amplifying the pain, and how to understand what's called sensory awareness stuff. So aside from physical things you can do, most of the people that I talk to initially, I give them not just this, but a whole bunch of other fundamental things that you can find online, and do everything that you can do on your own. Find your pelvic physical therapist and do myofascial therapy and massage therapy and all the other types of things to help bring your dial down, as well as getting somebody who actually knows what to do of the stuff I told you, which now am in the process of training three different people who have come and followed me. And now there's three more who are interested, because I want to pass on what I'm doing to some practitioners, including pain management person and a couple of other types of practitioners who want to learn this stuff. So I want this to go on beyond when I can do it. So thank you for your attention, and I
Can we ask
appreciate
you
it.
questions?
Sure, absolutely.
Okay. I wrote something down. If you're going to pelvic floor therapy and it's not helping, how long should you just go before you just give up on it and stop going?
Well, that's a really great question, because some people go for long periods of time and they may feel better for a day or two, but why are those muscles doing that to begin with? Some of whom, like I said on the talk that I just gave, are still trying to strengthen their core by doing exercise. And I have patients who are training for the triathlon and in the same time saying, I can't have intercourse because I can't be touched there. So you got to basically slow down your lifestyle and don't do the things that are trying to tighten you up. But many of those muscles are tight because the nerves are firing off. And why do the muscles go back to clenching again after the good physical therapist is doing the best she can? That's when the plateauing is happening. So I don't need, when people, and some people, when they start physical therapy by a pelvic therapist, it hurts because they can't even get their finger in the opening of the vagina because it's so sensitive. So sometimes just doing the therapy actually helps, either even to flare them up a little bit. So I tell people to find a massage therapist who does myofascial massage for the whole body, because their whole bodies, by the time they get to that level, have trigger points and sensitivities elsewhere, and stay away from ground zero until everything else comes down. And then to also use some simple products that have lidocaine in them, from the Desert Harvest Company that you all probably know for the aloe vera products. They also make Relivium lotion. Then if the people that are listening to me right now don't know about Relivium lotion, and they have any of the things that I was talking about, you can put Relivium safely anywhere in the vulvar area, anywhere in the vestibular area, anywhere over the clitoral area. And people come back and say even they're using it on their neck for their nerve pain in their neck and shoulder. It penetrates the skin, it gets into the fascial layer, it doesn't numb the skin. It just, over time, using it 2 or 3 times a day, will allow that sensitivity of that network of nerves in the vulvar region or the suprapubic region to calm down slowly. So the answer to your question is that, again, they reach a plateau, but unfortunately, the PTs don't have a doctor to send them to, or a practitioner that knows how to treat those nerves. And not just to give them high doses of Lyrica or high doses of Cymbalta. Even though I use some of those medications, I use everything low, slow, incremental, and carefully and safely. So it's not that I'm saying that all drugs that are used for chronic pain and chronic nerve pain don't work or shouldn't be used, but we're very careful in their use. But again, a combination of physical therapy, a combination of mind-body relaxation, a combination of treating the nerves, a combination of treating the bladder. I didn't even talk that much about the bladder. My easiest patient to take care of is somebody who just has IC. IC is not hard to diagnose if it's not complex with all the different issues that I just told you about. Any young woman who is the one who has to use the bathroom all the time and who um, cannot have penetration intercourse and has deeper discomfort and has to pee immediately after intercourse and has urgency and frequency that doesn't go away and is free of infection. And they're tender when you touch the base of their bladder. Those are the patients we love to see because just all the things that are supposed to help with IC help. When all those things don't help and the diet doesn't help, that means that something else is going on. And that's what that initial diagram that I showed you, if you put IC in the middle of everything, all the spokes that Dr. Nickel talked about should be taken care of as well. He and I are not talking differently, it's just looking differently. I'm looking at the pain that pulls everything together, and he's looking at, well, I see patients often have all these other things going on, and just blending those concepts together is what I'm saying. I don't know if that answered your question well enough or not.
Well, I have another question.
Sure.
Is
Uh,
it
Sorry, I want to be mindful of time and the fact that a lot of people have asked questions.
Yeah.
So Jennifer, go ahead, but let's try to keep the answer shorter, and then we can get to some of the other
this
questions.
is a short question. Is it true that I was told crossing your legs is bad for your bladder?
No, not true.
Now, the pelvic floor therapist told me that.
No, that's not true. And people that can't sit comfortably, I see people that are coming from getting a lot of pudendal blocks by pain management and so forth. And there's some pudendal doctors out there now that are telling people not to sit on the where the pudendals come out because it's just going to make the nerves worse. That's not true either. What can happen is that different positions, different exercises, different stretching, different physical activities will make things hurt more and make the pudendal or the muscles clench more. But that is a flare that is not going backwards or damaging any of the chronic things that have been going on for sometimes months and years. So no, almost all of those things are not correct.
Okay.
Great, thank you. Okay, so I want to encourage folks, as we said in the beginning, if you want to actually speak with your voice, use the raise hand feature in Zoom. And until I see one of those, we'll just launch into some of the questions that came in through the chat. Dr. Echenberg, there was a question, way earlier, when you were on your slides talking about trauma,
Yes.
and some books that had to do with trauma. And Jane asked, if so many people in the world suffer trauma of some kind, why aren't they all getting IC?
Why don't they all get IC?
Mm-hmm.
Because IC is a separate issue. IC is very, very common in my opinion. IC includes all those people that are still under the radar that are just thinking they have, quote, small bladders, or being told, yes, a lot of people have small bladders or can't hold their bladder easily. IC itself is a disorder. But when you have the whole system that dials up the whole sensation that you get when you have IC pain, that's what we're talking about. So it's trauma that it's causing, cumulative trauma causes the nervous system to, again, it gets into the difference between acute pain and chronic pain. What I'm saying is that chronic pain is a windup of the whole nervous system that becomes more super sensitive in many different ways, because some of the people that I see don't like loud noises, don't like heavy smells or tastes or loud noise, just like a migraine patient wants to, if they can feel the migraine coming on, they want to get into a quiet room, turn the lights down. And that's with the sensory awareness that they learn over time. Because then if they wait too long and they flare If you wait too long with an IC flare, nothing's going to help it until it's over with. And everybody has their own little way to do that, whether it's drinking more water or, getting into a quiet place and calming your whole system down, or an exercise that stretches some of the pelvic floor muscles. All of those things. That's why we call it complex pelvic pain, meaning not complicated, but complex, meaning there's more than two or three things going on at the same time. So when people have just IC, those are the people that do get treated. And if they can find somebody that believes them and actually understands that IC is a real thing, because 20 years later, I've been doing this, I can't believe that some urologists say IC doesn't exist. That just disturbs me very much, as it disturbs you guys. I don't know, again, if I'm answering everything.
It's great. It's great. And Dr. Echenberg, one of the things I meant to ask you to do, if you're able, is to stop sharing your screen, and then that will allow us to everybody to see more of each other.
Oh, I'm sorry.
Oh, no, that's okay. That's good.
Yes.
Oh,
Any
okay. So there was one other question in the chat. It's from someone who really enjoys doing intense weightlifting for fitness, and they're wondering if they can still do that without damaging their pelvic floor, or if they need to give it up.
I think weightlifting is one of those things that, yeah, again, I don't tell people to give up anything. I say slow it down, tone it down. As I said earlier, I actually have had some patients who are training for triathlon or things like that. Uh, I have one patient who is a horse person from the time she's 3 years old. The only time she did not feel the pain of sitting was when she was on the horse, because she was so passionate about horses. When I saw her, she had her own barn, she had her own 3 horses, and she trained horses and trained people to ride. And every time she's on the horse, she didn't felt no pain because she's so passionate about what she's doing. Often people do the heavy exercising and go to the gym and do the hip stuff and all of that, basically and they say that's the only time I feel better, because I'm working out and I'm doing what I'm passionate about. So I don't want to take people away from the weightlifting. I don't want to take them away from. I told that girl who had the horse issue that she needed to be around horses, because she was starting to think, I'm not going to be able to ride forever. And now she's still teaching, but she's not on the horse as much. And we did all the treatment type things that I showed you, and she is now back with her horses. So lifting, um, doing all the super stretching, all of the heavy duty um, exercising, I just would say tone it down to the point that makes sense to you, because you don't want to give up things that you are passionate about and you love doing. But to know that you're not damaging anything, you're just making it longer and harder for those muscles to learn how to relax.
That's great. I missed a question that I'm going to go back to, and there's another one that I think is related. But Linda had asked, what therapies do you use? And then someone else just asked, so if you just have IC, what's the best way to deal with it?
If you just have IC,
Mm-hmm.
well,
What works best is what they say.
if you just have IC, diet is the first thing. Low acid, drinking enough, being hydrated well enough, being aware that it's your bladder. And again, it's so hard to know who has just IC, because I was saying before, and you may have missed it, is that some people come in believing that all the pain across their lower abdomen and suprapubic area is IC. And when I just touch their suprapubic area just very lightly, they say, that's my bladder pain. That's my bladder pain. And then we put a little bit of local over the suprapubic area into the skin, and all that pain goes away. And in the meantime, I can push then deeper, and that's where their bladder is. So if you just push over the suprapubic area, again, hard to answer the question because, as I said before, if you just have IC, it's not hard to diagnose. Frequency, urgency, needing to know where all the bathrooms are, not being able to take a 2 or 3 hour car trip without stopping and needing to pee. And when all that's happening, you're clenching your muscles, and that's why physical therapy is helpful. But also, so many of you have a hypersensitization. So if you say irritable bowel affects a certain number of people, IC affects a certain number of people, uh, endometriosis a certain number of people, pudendal neuralgia a certain number of people. But what makes some of those people easier to treat and straightforward to treat is that they're not part of that 20% that has a predisposition for hypersensitivity of the nervous system. So if you just have IC and you don't have other overlapping stuff, then in my experience, that became the easiest thing to treat, because you change their diet, you have them understand that it's an inflammatory disorder, that it's not infectious. And we have so many people who come in, looking to all those labs out there that are looking for the super the invisible bacteria that are deep in their bladders. And there's lots of companies out there that I think that's overthinking it, and those companies are making lots of bucks. I think to keep it as simple as possible, dietary changes, avoiding acids. Basically, we tell people you don't have to stop everything, but at least understand that coffee, tea, soda, alcohol, um, citrusy things, and tomatoey things. You keep it localized to those things, and know that a lot of people don't realize that taking a glass of orange juice in the morning may be the reason that at 10 o'clock in the morning, an hour later, they're flaring. It only takes about 15 minutes for the acid in the orange juice or in the glass of wine or the cup of coffee. It's not the caffeine in the coffee that's the problem. Most people need that caffeine because you're exhausted. It's the acid in the coffee. So to go to low acid coffees, low acid teas, there's a whole bunch of things that, are on your site and other sites, that you can find out what is safe and what is low acid and so forth. So diet changes, understanding what's going on, that it's not always an infection when you flare. And even though you may have taken an antibiotic and you got better, it takes the same amount of days usually to get through an IC flare. And oftentimes the culture was negative. That's the other thing that people need to be realized, is that a dipstick or a phone call saying my IC is flaring up or my UTIs are flaring up again, you've got to get a culture done before being treated with antibiotics.
So I just want to make sure we covered Linda's question of just her very general question of what therapies does the doctor use. I heard you say a lot of things just now in response to people that just have IC, but is there anything else to add to that?
Yes, we do. In the beginning, I started doing bladder installations on a regular basis. We still do bladder installations. Actually, the medical assistant that works with me on a daily basis when I'm in the office teaches people how to do their own bladder installations, if they can. And a lot of people we see are from distances, so we teach them how to do that and send them little kits that have everything in it to do that. We also do trigger point injections even on the first visit, because I can find if they need a piriformis trigger point injection, and other, particularly these localized tiny nerve blocks. Instead of getting a pudendal block by somebody who's never seen you before in a hospital x-ray department, going for the sacral area and numb everything, what we have found, and what the Dr. Perry that I mentioned found way back in the 80s and 90s, is putting a little bit of local anesthesia where all of the peripheral nerves are, where the nerves end up. So what we're doing is different than going to get a pudendal block by somebody who's never seen you before, just because an MRI may have shown something. All of that stuff, it gets more and more layers of being told things that seem to be contradicting each other. The GI doctor saying one thing, the urogynecologist saying another thing, their hip doctor or orthopedic doctor may be telling him something entirely different. All of those things get very confusing. But when we're seeing complex pelvic pain patients, we're doing all of those things. So the first visit is a 2.5 hour visit online to explain all that, show a lot of the slides I just showed you, and to start to erase the whiteboard of so many of the misconceptions that have been told and the old wives that they've been told, and certainly some of the unfortunately discomforting so-called support groups that are out there. Some support groups are wonderful, and it's wonderful for people to share and to know that they're not the only ones having problems. But as I think you all know, that sometimes they're dominated in some cases by people who are just saying, I am more suicidal than you are. And that's not healthy. And I just want to say that people do need support, and their partners need to understand what's going on. And we try to have partners in on those first consultations online. If they can't be there, sometimes it's a mother, sometimes it's a daughter for an older lady, sometimes it's somebody who's close that they trust. And then we try to have them come in as well. And then the report that we give is to help the physical therapist, is to help the emotional therapist that they may be going to because of all the previous trauma and anxiety that they may have. So it's a team effort. And my goal is to see centers of excellence for complex pelvic pain, meaning to study this stuff at a university hospital. I'm currently working with a pain management doctors at the University of Miami, and I'm currently working with a osteopathic physician at the University of Kentucky, and her group works on the whole body, but she's the only one that's interested in working with pelvic pain and all the musculature around the pelvic area. So I'm working with three, and there's three other people, three other practitioners, doctors who are interested now in learning because it's popping up more and more. That unfortunately, none of them are urologists or gynecologists. That's all I'm going to say about that.
Okay, thank you. We have just one more question, and I know we've gone pretty long. But the last question I'm seeing is, do you still use DMSO as a bladder installation?
No, I never used DMSO because when I first started, there were when I first started treating IC, DMSO had been out quite a while. And I learned right away that there were people around the country because there were seminars on IC in the early days. They have kind of disappeared from the medical world, but in and around the early 2000s, there were seminars partially put on by Elmeron. So I went to a lot of those, and there were urologists and gynecologists and urogynecologists, and we learned a lot from each other. And then there was different mixtures of medications that were used that were far less difficult for the patient to go through than the DMSO. DMSO, you have to lay there for a while, and you have to turn from side to side, and then you have the garlic smell, and you have other things going on. So I did not use the DMSO. And we have really good success with the simplest of putting just lidocaine, um, heparin, and bicarbonate. And it's a simple mixture. It works as good as any other mixture that I've seen. You don't necessarily have to have antibiotics or steroids in those installations, but to keep it simple, and when you teach people how to do it, and they have the equipment at home to do it, it makes it a lot easier for them. So when they're flaring, they can do their own treatment, or they can have their partner help them do the treatment. So that's what I have to say about DMSO. I
Great,
haven't
thank
used it.
you. And I know that many of you may have some questions that you didn't ask that you still want to
Yeah.
ask. I know when we spoke yesterday to get ready for the webinar, Dr. Echenberg, you had mentioned that you can easily be found on the website at www.theechenberginstitute.com. And I see that we've just posted that in the chat. So if you guys want to, reach him that way, you can do that. So at this time, we're going to start wrapping up. I want to, first of all, Dr. Echenberg, thank you so much for being here with us today. This session was really engaging, and I know we had a lot of great questions and a lot of good answers. And there's been a lot of great comments in the chat, just being thankful for this session. So thank you so much. And we hope that
Appreciate
you
it.
all have enjoyed this webinar today and learned something new. If you found this session to be of value, please consider joining us for future webinars and share these opportunities with your community. We are excited to announce that the ICA has opened registration for this year's IC Awareness Month event, which is titled Together for Tomorrow, a virtual gathering and fundraiser for IC education, awareness, and action. This month-long event will consist of free content, including the following 2 new webinars. The first one on a topic that Dr. Echenberg just talked about, which is suicidality. That's about breaking the silence, talking about suicidality. This is a part 2 session from speaker Christy Ninneman, who spoke to us earlier this year. She had so much to share on that topic that she couldn't get it done in one session. So you can join us for that. And the second webinar is called Treatment Talk, and it's going to be featuring our newly appointed board chair, Claudia King, and ICA board member, Amber Carter. We also are going to be providing so much more content throughout the month. So we hope that you will make plans to join us. This month-long IC Awareness event is being offered free of charge, but you need to register in order to gain access to the content. The link is right now in the chat. I think we just put it there. It will also be emailed to you with the recording of today's webinar. So you will receive a link to today's webinar. So with that, this concludes today's presentation, and we thank you so much for joining us today. Bye-bye.